Μπορώ να το ανοίξω από εδώ? Okay. Okay, human breast is actually a modified sweat gland. We all know that its main goal is to produce milk, but the thing is that it has been, through the history, a hallmark, a symbol of fertility and good health. Breast cancer was discovered really early. It was first described by the Egyptians back to the 2500 BC. First written documents about breast cancer came from Hippocrates and then Galinos, who started more methodically studying breast cancer, and the truth is that we do still study that for many years. All we're doing now is have a quick run through the basic knowledge for anatomy. Breast, we'll talk about the female breast of the productive age. So breast lies in the front of the thoracic cage, between the second and the fourth rib, laterally to the sternum and, medially to the sternum and laterally to the mid-axillary line. Its diameter, average diameter, is between 10 and 12 centimeters, and the central thickness is about from 5 to 7 centimeters. Most of the breast is lying on the pectoralis major muscle. It's more than the 2/3 of it, and the remaining part is on the serratus anterior muscle. We have the tail of the breast that goes into the axilla, and we call that the tail of Spence. For topographical purposes and in order to reproduce the reports between colleagues, we have this clockwise topography of the breast. So we tend to describe the breast in 4 quadrants, using the nipple as the center of it. So we have the upper outer quadrant, inner upper quadrant, lower inner quadrant, and lower outer quadrant. And we all remember that this is the right breast. We all remember that the outer upper quadrant is the one which includes most of the breast tissue. So most of the breast cancers, they are revealed here. So always when we check the outer quadrant, we remember to check it twice, just not to miss anything. Actually, the breast it consists from the breast tissue and the fat. So we have the breast tissue lying into the fat. Sorry, I think I should use the mouse, yes. We have the breast parenchyma, which is actually the glands that produce the milk, and the stroma, which is the connective tissue that support the breast. The parenchyma now, it consists of 15 to 20 lobes and some of the ducts, some small tubes that carry the milk towards the nipple. Each lobe has approximately 30 lobules, and this is a lobule, and each lobule, it consists from 10 to almost 100 of acini. Those acinis are small boxes that actually do the job, actually produce the milk. Each acini has a small ducture that takes the milk into terminal ducts here. All these go down to segmental ducts, and then they consist the collective ducts that actually takes the milk out through the nipple, and the nipple has 10 to 15 orifices bringing the milk out. The terminal ductal lobular unit actually is the main functional unit of the breast, and this is our major concern. It consists of the lobule and the ducts. So we have the intralobular ducts, the small ducts into the lobules, and then we have the extralobular terminal duct, and all this unit, it's the main unit of the breast and also where the vast majority of the cancers come from. So concerning the ultrasound anatomy, we remember that when we're using the ultrasound probe, we can only see a slice of the tissue, so we always have to keep in mind the orientation of the probe and the aspect of the anatomy underneath. So a slice of the ultrasound imaging will give us the skin, the subcutaneous fat, then a bit of white tissue, which is the mammary zone, We have the retromammary fascia, and then the pectoralis major, and we can see the ribs and the lung underneath that. So we have the skin, subcutaneous fat, the breast tissue, that means the glandular and the glandular and the stroma one. Then we have the retromammary fascia, the retromammary zone, and then the pectoralis major. And this is how it looks like in ultrasound. So we have the skin, the subcutaneous fat, the glandular tissue, the intraglandular fat, lobules. So the glandular tissue is hyperechoic. It comes out white, and the black lobules between it, it's fat. And this is again is the skin. There are some anatomical structures like the ducts or the Cooper ligaments that can create some acoustic shadowing underneath. So in order to eliminate this shadow, all we have to do is apply pressure to the breast. And you see on this short video, applying pressure, how it clears out the imaging. So we have the skin and the subcutaneous fat. The Cooper ligaments, they are small white lines that start from the breast, like this one, start from the breast tissue and going out to the skin, or from the breast tissue to the thoracic muscle. We have the ducts, small linear, you can see some here, small linear structures, which are actually the ducts, and we can follow those towards the nipple. And of course, we have the pectoralis muscle. The nipple areola complex. Nipple is supposed to be at the center of the breast. It's about the height of the fourth or fifth rib. So it consists of a brownish skin with a nipple in the center, and then a disc around it which has sweat, sebaceous, and accessory areolar glands, which is called the areola. This is how we can see the nipple in the ultrasound. We can also sometimes distinguish the areola area. This is the fat, and these small structures, black lines, are the ducts that we can follow them towards the nipple. Nipple creates shadowing also, so we need extra care when we are scanning the retrial area region, apply more pressure or change the direction of our probe in order to have a better view of the retroareolar area. And this is how the dilated ducts look like, and we can always follow them to the nipple to make sure those are ducts. Concerning the mammographic anatomy, again, the gland with the stroma, they create some milky white shadowing, so they're all white. Fat is black, so we can see black lobules separating the rest of the breast tissue. Cooper ligaments are white lines that connect the breast tissue to the skin or to the pectoralis fascia. And the ducts are also white, and they are more obvious beneath the areola. Breast density is a headache during interpreting images. So with the BI-RADS 4th edition, we're all familiar with the density 1, 2, 3, and 4. 1 stands for the 25% of breast tissue, so the breast is rather fatty. Density 2 was for breast that had 25 to 50% breast tissue, and then, so it's about half breast tissue, half fat tissue. Then we have the 3, the heterogeneous, with a dense breast of up to 75% of breast tissue and only 25% fat. And then we have the extremely dense breast that can actually misguide us in misdiagnosing breast cancers. BI-RADS 4th editions, they came out 2 years ago, and now we changed the way we measure density. We have A, B, C, and D, and we avoid using the percentage, so we only use the explaining way, but it's about the same, just a matter of terminology. Concerning the vascular supplies, most of the vascular supply is from the internal mammary artery, and that goes for the arteries and the vein. And then we have the lateral thoracic artery, the thoracodorsal, we have scapular intercostal arteries, we have a huge a huge arterial area there, and the veins, for the veins, it's the same too. Now the axilla. The axilla is a triangular shaped or a pyramidal shaped area with the base in the axillary vein and the acme down to the point where the anterior serratus and the latissimus dorsi meet. So it's an upside down triangle, and it includes all the lymph nodes that are draining the breast tissue, and checking the lymph nodes during imaging or surgery. It's very important for staging the breast cancer. We tend, for topographical and surgical purposes, we tend to describe the lymph nodes of the axilla and separate them into 3 levels. The 3 levels are originated by the area of the pectoralis minor muscle. This is the major and this is the minor. So we have all the lymph nodes laterally to the pectoralis minor, level 1. Oh, sorry. So we have level 1 lymph nodes, everything laterally to the pectoralis minor. We have the level 2, which are the lymph nodes under the pectoralis minor itself. And then we have the level 3, anything medially to the pectoralis minor. We also have Rotter's lymph nodes, which is the lymph node between pectoralis minor and pectoralis major. This is the one. So during surgery, if we remove these Rotter nodes, we have to describe them separately in order for a proper staging. This is how the lymph nodes look like in the ultrasound scanning. It's a solid nodule, oval-shaped, and we have an echogenic fatty hilum, which is the landmark for describing a lymph node. And this is how a pathological lymph node would look like. Most of the time, what we're looking for in pathological lymph nodes is losing the echogenic hilum. We have the parasternal lymph nodes, which are deep into intercostal muscles. It's very hard, or it's almost impossible to evaluate them clinically. So during staging for breast cancer, especially breast cancers into the inner quadrants, we have to locate them preoperatively by ultrasound, and then under wire guidance, remove them during surgery. Concerning the nerves, the thoracodorsal nerve and the long thoracic nerve are the main nerves that we need to take care of during surgery. The thoracodorsal nerves are into the loose fat of the axilla, in the posterior surface of the axilla, easily recognized. Concerning the long thoracic nerve, sometimes it's loose into the fatty tissue. We know it comes out from the second intercostal space down to the fifth intercostal space, which is attached to the thoracic cage, but sometimes it's loose into the fatty tissue, so we have to take care not injuring that. Any questions? Okay, it's basic knowledge, I know, I'm sorry, but we thought it would be a good idea if we just refresh everything so we can keep on with the common language later on. Okay, in conclusion, it's good to know the anatomy. You don't have to know the anatomy, actually, because now you can have Wi-Fi access in the operating room, so if you forget something, just browse it and you'll find it in Google or YouTube. Okay, thank you very much. Please, you're on.